Hello, YouTube. Today we'll be talking about what stops people from seeking behavioral health care when they need it. And I'm going to do some introduction to popular help-seeking models that have been used and some of the factors that are measured in those models. And then we'll be talking about women's and then couples help-seeking, some of the cutting-edge stuff we've been doing related to these burgeoning areas of help-seeking research. So we're talking about help-seeking. We're talking about seeking help from who? Because you can seek help from a bunch of different sources when it comes to your mental health needs. A lot of people we know seek help from informal sources. Some folks seek help from mental health specialists, psychologists, psychiatrists, clinical social workers, etc. But we know that the majority of people, the first professional they see for mental health care is their PCP, their primary care physician. And generally, most help-seeking research looks at attitudes towards seeking help from mental health specialists. But there are some exceptions. And I'm focusing my research increasingly on seeking help from primary care physicians because that's where a lot of folks are going. And then what kind of help are you seeking? So again, it can be about attitudes towards psychotropic medications or other forms of treatment, but usually our research is about seeking talk therapy help. Most of the research that's been done is looking at people's attitudes towards seeking talk therapy, and different synonyms are used for that. So Anderson's health belief model is the first model we'll talk about. It's very popular in medicine, and it has been used to study help-seeking for general medical or physical health concerns, and there have been some people who have applied it for mental health in particular. And it says there can be a bunch of different factors that will help or hinder people from seeking help when they need it, and it chooses to categorize them into these three things. One is predisposing factors, so those are things like demographics, age, gender, racial background. Enabling factors, so these are things that help people get in the office and beyond barriers, so things like your income, do you have insurance coverage for mental health care, do you have social support that will help you access healthcare services, and then we have need. And need comes in two flavors. You've got evaluated need and you've got self-reported need. Evaluated need is what a mental health professional like ourselves would say is or is not wrong with the person. Hey, patient, you have this thing called depression, therefore you would benefit from treatment. You have need. But you also have self-reported, which is their own perception of what's going on for them. Are they just a little bit stressed, but that's life? Are they grieving? Are they depressed? So do they think they have a thing called a mental illness, and what does that mean? And then we know when we look at the literature, there's a lack of consistency in findings in terms of which of these variables do or don't matter for help seeking. And part of the reason is because every population has certain factors that are more or less important, so you see variation across populations. And even when you're sampling from the same population, a lot of times we're using different sets of variables. And so when you include different sets of variables, certain things will be significant predictors and some won't. And so you see inconsistency, and it can be quite maddening when you're reading the research and trying to find what's the truth, what factors do matter, because you see a lot of inconsistency. Levanthal's common sense model of self-regulation is useful. It focuses specifically on how people think about mental illness, specifically their own psychological distress. And it says that people develop illness representations, these beliefs, and these beliefs powerfully guide what they do about the thing. And so these representations are informed by all different places, the people in our lives, media, cultural norms, and it looks at a few dimensions. And depending on what published paper you look at, the dimensions can vary slightly in terms of what's mentioned. The first is identity. So it's this person's perception of what is this thing I'm dealing with? Is this, like I mentioned before, is this grief? Is this depression? Of all the symptoms I have, which ones do I attribute to to this mental health thing I'm dealing with, or which are from something else going on in life. Coherence is the degree to which they have an understanding of what they're dealing with. So is this stuff going on inside me that's causing me turmoil? Is it a mystery to me? Or do I know, hey, this is a thing they call depression. It's a mental illness, and it has these sorts of treatments. Like that, there's a lot more coherence to that understanding. Cause, what caused it? Is this because I have a chemical imbalance? Is this because I am a bad person, and I'm a weak person with a lack of willpower? Is it because I'm being possessed by demonic forces? Any of these can be explanations for why I'm suffering with what I'm suffering with. And some of these explanations might lean someone towards seeking professional help, or some would be active barriers to that. And then consequence, how will it affect me? Is this something I can brush off? That's just a part of life? Or is this something that I think is going to have serious consequences and I need to do something about it? And then timeline, is this a one-time thing I'm dealing with for a week and then it's done? Is this going to be with me for a long time? Is this going to be cyclical? For example, we know that major depression tends to be cyclical in terms of its presentation, right? It comes and it goes. And then controllability is how can it be addressed? And sometimes we break it down into personal versus professional. So is this something I can self-cope with or do self-help around? Or is this something I need a professional's help? So depending on where people fall on all of these dimensions, certain dimensions and places that they fall on it will help them get into Seek services, and some will not be very conducive. And so if we understand people along these lines, that can help us get information. And we know from some of the systematic reviews that consequence, timeline, and controllability seem particularly important for that. Pescolido's network episode model, this is out of medical sociology. It's a different perspective than a lot of other social scientists may tend to take, which are very focused on the individual in isolation. This, it says, it's all about social networks. It says social networks can provide symptom recognition so the people around you can see when you might be developing a mental illness and point that out to you. Emotional and material support, people around you can really give you support in terms of seeking help. They can provide you access to transportation. If you are a minor, you're absolutely dependent on your parents oftentimes to get that. That's an extreme example. But certainly people in the support staff in the schools or teachers can support or impede access. And then your social networks may have opinions about alternative medicine versus formal health care that can show up in terms of the advice that you get around that. I found it interesting in a 2015 article, they said, at least in this sample of Midwestern patients presenting with serious mental illness, that people were selective about who they told about the stuff they were struggling with, which makes sense. You might not necessarily proclaim it to everybody in your social network, but they tend to approach about 3 people. And they're selective, and a lot of times the people they approach are their partner or their mother. Those tend to be the most popular folks to go to when talking about this psychological thing they're dealing with. And this sort of research tries to measure someone's social network through questions like these. Who are the most important people in your life that you talk to about stuff like this? They get a list of the names of those people, and then they go and ask questions about every single person. The data collection can be pretty difficult and expensive to do, not only because it's longitudinal over time, but we're asking about a lot of stuff about a lot of people, so it would be 20, 30, 45 minutes per participant. In terms of what is it about people's social networks that can impact their help seeking, again, like we mentioned for Anderson's model, it can be complicated, and there are some reasons for this that are very helpful to keep in mind. Number one is having a bigger or more robust social network is not necessarily automatically a good thing or a thing that will help you seek help, because networks can be too large or too diffuse sometimes. Also, the influence of someone's network differs depending on that person's social location. So if Melanie or I are in the same family and in the same community, we may have the same people presenting with the same issue, but we get different advice. Maybe it's because I'm a man and she's a woman. And so that shapes people's perceptions and advice. And then, most importantly, I think, is that it's not the nature of the network itself so much as the cultural norms held by that network that dictate what happens next. Because if the people in that network are really big believers in westernized traditional medicine, in our approach, they might be more open to that person going to seek professional psychological help. If they are taking a different perspective and they don't trust the United States medical system and think about some of the injustices that have been demonstrated towards marginalized individuals within medicine, then they'd be less keen on sending folks to professionals. And so it's the cultural norms that tend to matter a lot. Also, it stresses that help seeking is a continuous process rather than a single choice. A lot of these other models tend to look at the big grand moment where someone decided to go see a professional, which sometimes that's the case for folks, but a lot of times it's this continuous process. It's an illness career, it's a trajectory where it starts with Googling stuff and talking informally to people, and then maybe talking informally to more people, and then maybe Googling about potential professional healthcare options, and then going to see your PCP, and then maybe getting referred to a mental health specialist, or having a bad experience with a PCP and doing nothing for 4 months, and then deciding to go seek a specialist on your own, and it's dependent on insurance, and all these other things. But it's this messy trajectory that plays out over time. And speaking to that, in this 98 study, they asked folks with serious mental illness about their narratives of how they finally got into professional health care. And 45% of them had that classic choice perspective where it was, I chose to seek professional help. I weighed my options and I made a choice. But actually about a fourth of people reported more of this coercion narrative where they felt forced or pressured by the people around them to seek help. And of course that's particularly relevant when we're talking about more serious mental illness like bipolar disorder or schizophrenia or other things that can be extremely debilitating that tends to pull more of that coerciveness. But it can also happen in the context of things like major depression or anxiety. And then separate from coercion and choice was this muddling through, which is people weren't really actively seeking help, nor were they actively resisting it. They just felt buffeted about and found themselves in treatment. They kind of stumbled through it and were shaped by the forces around them in sort of more of this passive frame. And the fact that these two latter narratives exist is very helpful when we think about how are we studying help seeking. So if we're only looking at the things that dictate people's one choice moment in time, we may be missing some of this. So it's a good reminder for all of us. Theory of planned behavior is what folks in the Hammer Lab use a lot of. It says that the best predictor of who will or who won't seek help, do the actual behavior of making an appointment and going into the office for professional psychological help, it's people's intention. So we might assess intention by asking something like, I intend to seek help from a psychologist for my depression in the next 3 weeks. Strongly disagree to strongly agree. And that's how we would supposedly measure someone's intention. And then, in turn, the best predictor of intention are 3 big things: people's attitudes, subjective norms, and perceived behavioral control. Their attitudes are how good or bad they think seeking help is. Because if someone thinks therapy, for example, is ineffective, that's not going to be very conducive to them wanting to seek help. For subjective norms, it's people's perceptions of what the people around them think about the possibility of seeking professional help. And they come in 2 flavors. We don't always separate out a measurement of them, but I think it's best when we try to. The first is it's injunctive. It's what people think I should do. My mom, my aunt, my friends think I should or should not go see a professional. Descriptive is more, if those people were in my shoes, what would they do? You know, it's like talk the talk, walk the walk sort of thing. So descriptive can also uniquely account for variance in who will or who will not intend to seek help. And then we've got perceived behavioral control. This gets at more of those classic barriers and also the attitudinal barriers in terms of control and self-efficacy. So do I feel like I have the power or the capacity to seek help? Because if I don't have the financial or the logistical means to go for an hour once a week to seek help, I'm not going to do it. It's not possible. And not only is there that control, but there's also this more subjective sense of self-efficacy, which a lot of times we think about being tied to what's called mental health literacy, which is having the factual knowledge about mental illness and about available treatment options, because you need to know stuff about mental health and seeking health care before you do it. You have to know what's possible. And so perceived behavioral control can matter. And we find when we do research that depending on the population, sometimes attitudes is the most important thing. Sometimes perceived behavioral control is the most important thing. Sometimes subjective norms is the most important thing. It just depends on the nature of the folks we're asking about. And in theory, attitude, subjective norms, and perceived behavioral control impact behavior only through intention, people's planned intention to seek help. Though there's some work out there, including some of mine, where we look at other things like people's spontaneous willingness to seek help, but that's for another talk. And it emphasizes that any other distal variables that are earlier in the causal chain, they only impact behavior through these mediators. Okay, so if something like trust in the healthcare professional or economic barriers or mental health literacy is to have an impact on help-seeking behavior, it's because these things impact attitudes, subjective norms, and or perceived behavioral control, which in turn impacts intention, and intention is what drives behavior. So that's what the theory of planned behavior says. So when we do studies, we'll oftentimes pick our favorite distal variables and put them on the left side and look at how these connect to attitudes, subjective norms, perceived behavioral control, and then intention. And then if we're fancy, we're also measuring behavior, which requires a longitudinal design where we ask them at time 2, okay, did you end up seeking help or not? Other distal factors are contextual factors, so the anticipated cultural competence of the provider. If you're thinking about going to see a mental health specialist or a primary care physician, but you worry that they're not going to understand your cultural frame of reference, or worse, that they may microaggress against you because of your cultural identities, then you're not going to be too keen on seeking help from that person, because why would I subject myself to that? They're not going to get me. They're not going to respect me and where I come from. Medical mistrust is related, and this gets at some of what I was mentioning earlier, where professional medicine, psychological and physical in this country, has a history of being unkind towards marginalized individuals. So, for example, black folks, there's a history of unethical medical experimentation in which black folks have been the subject of that experimentation. And what that means is that marginalized individuals have learned not to trust medical professionals because medical professionals have really earned that distrust. We've really done decision-making and done unethical and sometimes illegal things in the name of science or medicine that have been deeply harmful to people we care about. And so there's this medical mistrust that folks can have of the establishment. Treatment also is very westernized. So whether we're talking about seeking help from a PCP or the traditional 50-minute hour of talk therapy, it's from a westernized frame where it's the set amount of time at this time and you must be on time or there are consequences or you get charged if you don't show up on time. It's in the sterile office environment. It's supposed to be utterly confidential, where we're not bringing in neighbors or community members or other people in the extended family to talk about how to help this person get better. We might be doing that with kids or adolescents, but generally not with adults. So there's all these kind of implicit Western, typically white cultural norms around what does good mental health treatment look like. It's from a perspective of someone like me, a white male. And sometimes this works for folks who are different from myself, and sometimes it doesn't work for other folks, where mental health care would need to look different. It would need to be less scheduled, more spontaneous, more involving of the people in my social network. And so we have to think about balancing what we think is good ethical practice with meeting people where they're at and providing services that are going to be a good fit for them. And then we've got constructs around gender and ethnic socialization. So for some people, being self-reliant or being emotionally in control or stoic is very important to them. And if that's the case, seeking talk therapy may not be a good fit because it goes against some of those norms. Likewise, for some folks, there's a cultural norm around being selflessly caring for other people and not having so much time or energy or space to care for oneself. Seen from that perspective, seeking help is kind of selfish because, my first duty is to take care of the people around me. I don't have time for myself and for the indulgence of therapy, and that can be very real. Likewise, we got stuff around stigma. So saving face so as not to bring shame to one's family if you were to reveal to the people around you that you were dealing with a mental illness or seeking help. And likewise, there can be cultural proscriptions around airing one's dirty laundry, which is kind of showing to the wider world that, hey, I'm dealing with some stuff and this might look badly on myself or my community. And there can be a stereotype threat pressure around that. And then we've got all different sorts of flavors of stigma. So just really briefly, there's stigma of having a mental illness, but there's also stigma of seeking help for a mental illness. They're additive. Both forces can be here simultaneously. And we find that the seeking help stigma can be a bigger barrier to treatment than the stigma associated with the mental illness itself. And then mapped onto this mental illness by help seeking, you have these then different types of stigma as well. So it forms like a 2x4 matrix where you've got public stigma. What do I think people out there in society think of people with mental illness or people seeking help? Anticipated stigma. Do I anticipate if I'm going to go seek help that I'll be targeted or harassed or thought less of by other people? Self-stigma. Would I think less of myself if I was to seek help? And this tends to be some of the strongest predictor of your attitudes towards seeking help rather than these other types of stigma. And then you got personal stigma, which is your own negative views of those other people who have mental illness who can seek help. This might be less likely to make you less likely to say be supportive as someone in someone's social network. So these have all been studied to varying degrees. In the interest of time, I will not talk about some of the studies that we've done, and I will hand it over to Alyssa to talk about women in help seeking.
Hello, everyone. So Dr. Hammer talked a little bit about the distal variables. So if we think of help seeking intention or behavior over here, what over here is predicting the theory of planned behavior variables? And we say, we pick our favorites. And my favorite is talking about gender and gender role socialization. And specifically, it says women, and I'm going to be talking about men and kind of ending with women. Kind of want to run a little bit. Dr. Hammer mentioned some factors that go into help-seeking behavior and help-seeking intention. Stigma is one. Accessibility, so can I get there? For example, can I climb the stairs that get up to the therapist's office? Things like that. Cultural mistrust of mental health providers, so both anticipated cultural competence and also, as Dr. Hammer mentioned, unethical experimentation for a long time by medical and psychological providers on marginalized groups. But the one that I'm interested in talking about today is this social construction of gender. So we know that more than half of adults with mental health concerns in the past year did not seek help. And I'm also going to tell you that this is a best case scenario number. And so when I say that, what I mean is, when we say 60% of adults, we mean 60% of adult white women who could afford to go, who wanted to go, and had the mental health concerns that they needed to go. And as you can see over here, this breaks down precipitously once you start accounting for people, specifically, in this case, we're looking at Black Americans, Latinx Americans, and Asian Americans, but essentially once you start getting outside of the demographic of middle-class white woman, the help-seeking utilization drops off precipitously. And some assumptions that I'm going to be making kind of during this presentation is first that gender is a social practice. So gender is both assigned to you at birth by as your parents see, you come out and your parents say, oh, it's a boy, it's a girl. And I also believe that it is performative. So when I get up in the morning, I put on a lot of makeup. Sometimes I put on heels. And that's partially because I need to impress on the world that I am a woman. That's part of my performed experience as a woman. And so sometimes that performance is to a literal audience, a real audience, and sometimes it's to an imagined audience. And when I say imagined, what I mean is that even if when I'm making decisions that are intensely personal, even when I'm making decisions that, at least according to my cultural socialization, only affect me, so the decision like to go to therapy, I'm still taking into account what this imagined audience thinks, and how will that affect this imagined audience's understanding of me as a woman. The last thing I want to frame is that there are more than two genders. However, U.S. society specifically, and like U.S. white society, frames it as two. And so I'm going to be talking about it as a binary, not because that's what I believe, but because everyone of all genders often gets crammed into this binary construct. And so another disclaimer is that you can't really talk about gender unless you talk about race, because your experience of your gender is highly racialized. So Kimberly Crenshaw originally coined the concept of intersectionality. So the idea that specifically she was speaking of Black women, their experience of being women is cannot be split apart from their experience of what it means to be Black. And that's true also with with many other identities, including abilities. So disabled women, their experience of being women is going to be different depending on their ability status. Sexual orientation, queer women occupy a different social strata than heterosexual women. And ethnic or national origin. So your experiences and the cultural messaging you experience around gender cannot be pulled apart from your identified gender. And typically, when we study women and we study gender, what we're actually studying is white women. Most academic, most psychological studies are conducted on first-year college women, first-year college psychology majors, which tend to be wealthy white women. And also, you'll see like the term like Western masculinity or Western femininity or Western therapy. And when we say Western, typically we mean white. And the other thing to frame too is that even if you are not a white person, your expectations and gender role expectations are framed in whiteness. So as in you are still expected to and asked to conform to white expectations even if you yourself are not white. So yes, my presentation is on women, but we have to talk about men first. Because most of the work that has been done in help seeking and gender is done on men. And that's for a very good reason, is that men don't seek help. When we say 60%, again, that is a best case scenario for wealthy white women. For men, the number appears to be significantly lower, including for white men. And so you will see in almost every study of men and help seeking, you will see we need to study this because men don't seek help often enough. Men are also significantly more likely to die by suicide, for example. Like, this is a real problem, and it's why this work is being done. However, so the constructs that usually come to mind and usually show up are first that there are a couple of constructs that show up when we talk about men and why men don't seek help specifically. The first is the concept of self-reliance. So I can't ask for help because that would damage my understanding of I need to solve things on my own. The second is emotional control. So the sense of I need to not share my emotions with others. And that's not just about solving my own issues, but also just keeping my emotional experience to myself and potentially my wife. And I say wife specifically. Typically our understanding is that men, especially heterosexual men, kind of has this sense of I cannot share my experiences and my emotional experiences except with my female partner. And this can also show up in a pathological way, and when it does, we call it alexithymia. So alexithymia is the clinical definition for when people, and often in this case men, have difficulty not just expressing their emotions, but even naming what they are. I don't even know what's going on with me. How could I possibly talk about that with a therapist? And the last is the idea of masculinity contingency, which is a fancy academic term for turn in your man card. You will not be a man if you do X. In this case, you will not be a man if you do therapy. And that masculinity threat is incredibly strong for men broadly. And so this fear of, if I'm not a man anymore if I go to therapy, that sense is so strong for me that I'm not going to do something that could damage my understanding of myself as a man. And you said, like, Alyssa, this is a presentation about women. Where are the women? Well, I took the liberty of Google scholaring. I Googled women and help seeking. A woman in help seeking, I set it to the last 5 years. This is the first 4 results. Feels good. So the obvious one is like, what? But I also want to call your attention to a couple of other things. First, you will notice that much of the help-seeking literature in women is based on very strongly gendered variables. So in this case, you'll talk about infertility. So help-seeking for infertility, help-seeking for not being able to have a baby. You will talk about help-seeking behavior in Mexican women for intimate partner violence. So specifically for women experiencing, presumably, intimate partner violence from their male partners. And then help-seeking amongst women survivors of domestic violence. Again, the way we talk about women and the way we talk about help-seeking is using these incredibly strongly gendered outcome variables. And there's very limited research onto what about like just the experience of distress? Like, I'm depressed, I'm anxious, I'm having a hard time at school. There's really not that much literature. And oftentimes what you'll see is women seek help more than men, therefore we don't need to talk about women. And it's like, well, yeah, but even best case scenario is still 60%. 60% of distressed women, that's still almost half of distressed women, best case scenario, who are not experiencing or who are not receiving help. The last is that most of the research that's done is often qualitative, which is great, and it generalizes very specifically to the process. However, there's not a lot of evidence to understand what factors are actually going into women's decisions to make help, except for in these very specific and qualitative experiences. So the three, I'm wanting to look at 3 factors that are associated with gender role socialization, specifically that are experiences of women or like relational schemas as it applies to women. So I'm not saying these are feminine gender role norms, but I am saying that they are expectations that are generally assigned more to women than to men. The first is I want to look at presentation of perfection. And I'm using this intentionally broad language because while this is kind of, again, rooted in whiteness, this is a problem that academia has, this kind of flavor of I need to be perfect, I need to show everyone that I'm good at things, I need to keep it together, shows up in a lot of kind of more culturally nuanced constructs that get talked about. So I've thrown 4 up here. So effortless perfection was studied specifically in white college women. The strong black woman stereotype, so I can't show anyone that I'm not okay because otherwise I can't be the emotional lodestone for my family. Marianismo, so in Latinx women and Latina women specifically, talking about this self-sacrifice, this I must literally be like the Virgin Mary, I must sacrifice for my family, and I must maintain this picture of serenity. And the last is saving face. So very broadly in Asian American, like again, very, very broadly in Asian American culture, what you'll see is a sense of I cannot show my distress to other people, otherwise I will bring shame or damage upon both me and also the people around me. And the people around me is specifically, I think, gendered as it applies to women. The second that I want to talk about is ambivalent benevolent sexism. So when we talk about sexism, we usually are saying like, well, like women are bad at stuff, women are bad at math, women can't vote. But the thing is, sexism has evolved and has gotten a lot sneakier, and so now it oftentimes looks like women are special, women need to be taken care of, women need to be placed on this pedestal because they're so important and fragile. And so I'm a little bit curious as to if women who are willing to endorse these items and willing to endorse this sense of sexism, are they more likely to say, well, yeah, I am fragile and I am vulnerable and I do need help? Is that going to facilitate help seeking? I don't know, because this study from 2012 of the dependency stereotype, which is very similar to this, which is women who are basically primed with women need help, women are special, women are dependent on men, they were actually less likely to endorse help-seeking intentions. So I don't know how this is going to show out. The last is emotional intelligence. So when I talked about emotional control or alexithymia earlier, the sense of I can't express my emotions, and even if I could, I don't even really know what they are. This is the other side of this. Because when I talk about these 2 variables, they're very negative. They're like, oh, it sucks to be a woman. And like, I don't want to devalue that experience, but I also want to say that like, this is a good thing. We are like, the fact that women are socialized to be emotionally intelligent is a good thing. I want more of that in all people. And so I'm thinking that emotional intelligence, and women are specifically kind of socialized to be good at both identifying their own emotions and those of those around them, and also being able to communicate them with other people. And I'm assuming that this is going to facilitate help seeking. This is my model. I'm aware of time, and so I'm actually not going to go through it for now, but if you all have questions, I'm happy to answer them. Sure.
Hi, everybody. Nope. Okay. So I'm going to be talking about help seeking for romantic relationships. So we're talking about couples, my favorite topic. So kind of setting the framework. In the United States of America, about 90% of people will be married at least one time in their life. And of those 90% of people, roughly 48% of them will get divorced at least once, one time in their life, or more. And so what that tells us is that romantic relationships for most people are one of the most important and human experiences that people have. And that's not for everybody. For a large amount of us, they're really important. And even though we know that they're important, we see really low help seeking and utilization of couples therapy. So I'm not going to go over the gender differences in such detail because Alyssa covered that really, really well, but it is important to say that some of these gender differences do come into couples help seeking as well. And I'm talking specifically about heterosexual romantic relationships, and what I mean by that is one male straight partner and one male or female straight partner. And within that context of heterosexual relationships, we see gender differences on who is kind of the emotional barometer of the relationship, and shocker, it's women. And so women are typically the one dragging their male partners to seek couples therapy, and ironically enough, the men usually benefit significantly more than the female partners from couples therapy. So they don't want to go, but once they get there, they actually see higher increases in relationship satisfaction and all of these fun things. So part of the kind of theme of my whole presentation is that through all the literature I'm about to talk about, when we're talking about couples, we're mostly talking about white, Christian, heterosexual, married, monogamous couples. And everyone outside of that very specific couple type doesn't really get represented very well in the literature. So when I'm saying couples, that's usually what I am talking about, but those experiences in help seeking are probably going to be different depending on couple type, and it's something that's definitely a gap in the literature. So first, why do couples seek help? And for the most part, it's reactive. So what I mean by that is it usually takes about 5 years after something bad happens in a relationship for people to actually go into couples counseling. So if infidelity happens in a relationship, it usually takes about 5 years to go to couples counseling if you go at all. And it's not really seen as preventative, so it's not seen as like a checkup model, how are things going, let's stay healthy. So some of the common reasons why people do seek help are things like low satisfaction, staying together for the children, general fondness of their partner, even if things aren't working very well in their romantic relationship. But the literature usually identifies these reasons from the therapist perspective and not from the individuals or the couple's perspectives. So these are basically common reasons why therapists think people are coming to couples therapy, which is a gap in the literature. But broadly, most of the literature focuses on why couples do seek help instead of why they don't seek help. And one thing to know is that the kind of number thrown around in couples literature is that about 36% of couples seek help for relationship distress before they get divorced. But the problem with that number is that that's talking about any type of help seeking, including finding a book about romantic relationships. But when you look specifically at how many couples will seek professional help before they get divorced, so we're talking only about married couples, it's about 19% of couples. So why people don't seek help seems pretty important. So why don't couples seek help? The big thing that's been starting to be identified within couples help-seeking literature is environmental barriers to help-seeking. So this is things like finances and transportation and childcare is regularly identified when you're talking about couples help-seeking. And Dr. Hammer spoke really well about this earlier, of all the different types of barriers. And when we're talking about couples, these things are double oftentimes. It's not just one person taking time off of their day to seek help. It's now two people or more. And it's interesting because there's some really cool research going on around the country with Dr. Cordova at Clark University and Dr. Christina Gordon at University of Tennessee. And they're specifically trying to reduce these environmental barriers for low-income couples. So they're doing things like home visits, like free childcare, like all weekends and nights, and very, very accessible, very low cost, if it costs anything at all, and people still don't want to go to couples therapy. They don't want to do it. And so it tells me that there's something else that's going on. There's something else that's stopping people from seeking help when they could use it for their romantic relationship. So the couple of things that have been identified, and it piggybacks really well off of what Dr. Hammer spoke to earlier, is this idea of perceived need. So again, it's reactionary, it's not preventative. We don't need to go to couples therapy. We're not going to get a divorce. Everything is fine. We only go to couples therapy when things are going so poorly that we have to. So perceived need is a huge barrier. People don't think they need it. And the next one is self-stigma. And so there's not a ton of research on self-stigma in couples help-seeking, but there's a little bit that's been coming out. It's actually also coming out of Dr. Hammer's lab. So Doug Spiker has done a little bit of research about why, about men help-seeking for couples therapy, specifically through the lens of masculinity. And they found that there are negative correlations with restrictive emotionality. Always get those words wrong. Yeah, I did. And independent or self-reliance. So as people adhere more to these traditional masculine norms, they're less likely to seek couples therapy. And the last kind of piece of it, and it's really kind of new, it's a different flavor of stigma. So it's not just this idea of what do I think of myself for going to couples therapy, or what does someone else think of me. It's also, what does my partner think about going to couples therapy? What does my partner think of the relationship if I say we should go to couples therapy? So the last kind of piece of it are the gaps and next steps. And the big part that I'm interested in is the lack of representation in different couples types in this research. I spoke a little bit about it at the beginning, and that's really where I see my research going. I'm specifically interested right now in help seeking for same-gendered couples and some of the barriers that might be unique to that population through the framework of minority stress theory. And so some of the stuff on the left of these models we keep talking about are going to be different depending on who we're talking about help seeking for. I'm hoping to expand it using the theory of planned behavior of the very little literature that does exist about help seeking for couples. They use something called stages of change model. And I'd really like to, for all the reasons Dr. Hammer talked about earlier, adapt it and use more theory of planned behavior. And again, just kind of fleshing out this maybe unique stigma for couples counseling. And those are my references.
Do we clap? I don't know if we clap.